Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings. And today I am really pleasure to have our great speaker and great professor, great scientist as a speaker today, Professor Hesham Elsayed. He is well known. He is the emeritus professor of nephrology and medicine at Shams University. Professor Hesham is the president-elect of Egyptian Society of Nephrology and Transplantation, and he is the chair of the hemodialysis chapter in Egyptian Society of Nephrology and Transplantation, and the director of renal replacement therapy fellowship in World Kidney Academy. Professor Hesham is well known and غني عن التعريف زي ما كلنا بنقول. And the topic today is about anemia management in CKD and end-stage kidney disease. We will listen from Professor Hesham about the recent updates, what's recent, and what are the guidelines to use nowadays in management of anemia, which is the most, I think, the most prevalent topic we face every now and then and in our clinics and in our practice while dealing with CKD patients and end-stage kidney disease patients on renal replacement. I am really pleasure to have Professor Hesham today and waiting for the very interesting lectures. Before I leave the floor to Professor Hesham to give his lecture and start his talk, I would like to thank Dr. Rami Abu Bakr al-Shahat, the coordinator today of this meeting today. He is the consultant of nephrology and transplantation in Egypt and Oman, and he is the fellow of MRCP, Egyptian Fellowship of Nephrology, and Dr. Rami is one of the very active members of ES and CME chapter. I would like to thank him for his all activities. Thank you for all professors, Professor Saeed Khamis especially for joining us today. And I can expect from the audiences and attendances that a very hot discussion after the lecture. Please, Professor Hesham, the floor is yours. Start your lecture, and we'll come to you again for the discussion after you finish. Thank you so much.
Thank you, Dr. Yasser and Dr. Rami and Dr. Saeed and other colleagues and friends. Again, in our ESNT, our home of educational citadel, all over the years, we are focusing in different topics, and our mission is to enrich all members of the ESNT with a good materials. Today, I will have tackling anemia management in CKD and end-stage kidney disease in a takeaway model, just to have a takeaway model with multiple points and the steps that we have to stop on as takeaway messages in different aspects. Considering the latest KDIC guidelines 2025, it is just up till now, it's still a draft, expected to have the finished paper on January 2026. So let us have here what is the new in the anemia management, iron therapy, and ESA and the other competitor like HIF, when to give and when to stop. So let us have some slides. It's around 86 slides, but I will focus on some of them as the messages as discussed earlier. So our agenda today will have 5 main points: some tricks in samples and introductions. Number 2, iron therapies. Number 3, boxing between ESA and hypoxia-inducible factor, proline hydroxylase inhibitors. And number 4, KDIC anemia management 2025 draft, and finally, blood transfusion. Just to have a practical adjustment of hemoglobin, the dilemma when to take the blood sample for patients on maintenance hemodialysis. As a rule, midway between different sessions is the midweek pre-session seated sample is a standard. So between that, we are discussing between Monday and Tuesday, and the patient should be seated, which is a new way to focus on that. Don't have a hemoglobin level in the early week or the long interval of dialysis, but in the midweek, and the patient should be seated. Number two, sampling such as patient posture and interdialytic weighting affects the measured value of pre-dialysis blood hemoglobin concentration. You can have that plasma distribution upon positioning of the patient due to seated to supine postural change, dilute the
ثانية.
So let us have some of the tricks again for the patient in midweek and seated sampling that reporting account for increase of intradialytic weight gain. Every 1% increase relative to dry weight lower pre-hemoglobin by 3%. And for positioning for supine sampling, hemoglobin should be increased by 5%, which is around 0.5 gram per deciliter. Since the average midweek pre-session intradialytic weight gain and dry weight is 3%, so hemoglobin should be increased by 3%, which is equal 0.3 gram. Accordingly, I think that can explain some of the variation of patients' hemoglobin between different sessions. In general, my first message is when you are measuring pre-dialysis hemoglobin, please keep the patient in the seated position and in the midweek, and always do the same every month. The second important point is stressing that, and in practice from the KDIGO guideline, in all patients who are not fitting for anemia management or unexplained anemia outstanding that of CKD or on dialysis cannot be explained, should induce all of these following 10 points, including blood smear, haptoglobin, which is difficult to measure, lactate dehydrogenase for hemolysis, which is common in patients on dialysis, for C-reactive protein and inflammation, vitamin B12 and folate, which is common, abused in measurements frequently, liver enzymes, serum protein electrophoresis and immunofixation, in particularly in those patients who are elderly above 50 years old and on dialysis of unexplained origin. Still, myeloma can happen in patients on dialysis or transitioning from different monoclonal gammopathies prior to dialysis and into dialysis. Thyroid stimulating hormone, we're always stressing on that, but thyroid stimulating hormone in patients with hypothyroidism, the mean corpuscular volume is usually macrocytic, not microcytic. And finally, stool analysis for occult blood. There is association between hemoglobin level and mortality in CKD patients in different meta-analyses. The hemoglobin should be between 10 to 12, and in the recent guidelines between 10 to 11.5. In our Egyptian guidelines, we are recommending the hemoglobin between 10 and 11 6 years ago, and it is still valid even in the KDIGO guideline 2025. While hemoglobin level below 10 gram, the hazard ratio is 1.7, so minimum decrease of hemoglobin carry more risk of cardiovascular disorders and death. The second important point is the treatment emergency of all patients with anemia as fast as possible, because outcome of early versus delayed anemia treatment in non-dialysis dependent CKD is associated with a high risk of renal events. It is still questionable about progression of CKD. However, it's well known that the risk of cardiovascular events were increased, suggesting the importance of early intervention before hemoglobin below 9 gram per deciliter. In the cardiorenal patient, which is a common and nephrology prospective including all of these 5 points. Because anemia significantly impacts the prognosis of both heart failure and CKD, the use of sodium glucose cotransporter as a universal treatment in patients with cardiorenal patients, if GFR above 20, will improve anemia and has many factors and mechanisms. It's out of our talk, but sodium glucose cotransporter improve anemia with decreased oxygen consumptions of the renal cortex. The intravenous iron had shown consistent benefits in patients with cardiorenal syndrome, and it is a must of treatment in any cardiorenal syndrome who develop anemia. We have to check for iron profile. The iron deficiency may be present in patients with heart failure independently of anemia. And this is another question of, should we treat patients with iron deficiency even the hemoglobin is still in the normal range? Yes, we have to treat because iron is an important one in many of the metabolic and physiological rules. And finally, in cardiorenal syndrome, consider erythropoiesis stimulating agents if hemoglobin remains below 10 grams per deciliter. So this is 4 to 5 main points how to manage anemia as a consultation of nephrology in cardiorenal syndrome. And the etiology can be due to tissue hypoxia, decreased erythropoiesis, renal impairment, excessive sympathetic nervous system, sodium and water retention, and for sure, some of the dilutional effect of hypervolemia. On the left panel, you can find that with patients with heart failure, remodeling of the myocardium and the fibrosis and RAS inhibitor per se can affect the anemia, well-known effect of the RAS inhibitors. Coming to the total body iron, which is around 50 milligram per kilogram body weight, the 24 milligram of iron per day is necessary for red blood cells production. However, the dietary requirement is only 1 to 2 milligram. So among 24 milligram of iron required per day, the dietary iron is only 1 to 2 milligram. However, the remaining is coming from what is called iron recycling, which meaning that iron is recycled from different parts, including the red blood cells, the spleen, the macrophage, the liver, bone marrow. All of this is the main source of iron. So iron deficiency takes too long time before depletion of the iron stores, before significant hemoglobin drop. We have two important molecules here, or transporters. One is hepcidin, which regulate iron absorption and iron availability, and we'll come into hepcidin later on. And the important one is the ferroprotein, which is an exporter of iron into the circulation. That's why hepcidin inhibit iron mobilization and iron absorption through this transporter of ferroprotein as an exporter on the cells. So iron hemostasis involves 3 cell types. Number 1, duodenal enterocytes with absorption. Number 2, hepatocytes and the others, storage and signaling. Number 3, the tissue macrophage, storage and reuse. All of these are commonly called number 2 and 3 into recycling of the iron. The intestinal absorption is generally below 10%, which is equivalent around 2 milligrams per day of ingested iron, and about 95% of iron needed for hemoglobin synthesis is provided through macrophage recycling of iron from phagocytosed senescent erythrocytes. So the roadmap of 4 steps of iron, including the following. Number 1, enterocytes iron acquisition as well as macrophage release of recycled iron is regulated by hepcidin. Cellular iron is stored as iron oxide within the ferritin. Number 3, iron circulate in plasma to transferrin. And number 4, the master regulator of iron absorption or mobilization is hepcidin that bind again to the important exporter, which is called ferroprotein, that induce its internalization, preventing cellular efflux of iron. It's difficult to be understanding. The next graph will show you. Here in this graph, while iron are transported from the duodenum and the others, are expected to be bivalent metal iron transporter, including the enterocyte, and on the other side of the enterocyte coming to ferroprotein. And this ferroprotein mobilizes as exporter of the iron from the intestine to the blood vessels. And this is a very important step of negative effect of hepcidin to block this part of ferroprotein for moving the iron from intestine and from macrophage, as ferroprotein is also present in different cells. So reduced iron absorption can happen with Helicobacter pylori, autoimmune or atrophic gastritis, inflammatory bowel disease, bariatric surgery, long-term use of proton pump inhibitors, celiac disease, very rare hereditary conditions such as atransferemia and iron refractory, with chronic inflammation, cancer, rheumatological disorders. All of these can increase hepcidin and block the ferroprotein transport of the iron. And the final step is the transferrin, which carry the iron to different parts. Coming to erythropoietin, what is known is the pluripotent effect. It's not only for erythropoiesis. Erythropoietin is a human erythropoietin hormone, 30 kilodalton glycoprotein. The kidney are the master and the primary source. However, cerebral and hepatic can be controlled, can release some of erythropoietin, but with a small number, and this explains why HIF can increase even in failed fibrotic kidney erythropoietin release. EPO is an essential factor for other viability and proliferation of erythrocyte progenitors in response to anemia or ischemic stress. In high altitude, EPO production is induced. The main facet of erythropoietin physiologic and metabolic response include its expression is not restricted to erythroid tissue. It's present in endothelial cells. And this is why ESA can induce hypertension by stimulation of endothelial cells, increasing endothelin-1 secretion that may exacerbate adverse vascular effect, with critical point of high ESA, and will come later. Don't give too much of ESA in patient not responding for erythropoiesis, because you will take the disadvantage and the complications of ESA without benefit for the patients. Also, EPO receptor in different organs and the neuroprotection decrease inflammation. As a pluripotent, there is some literature about patients with cerebrovascular disorders can be benefit from erythropoietin, and the brain, particularly neurons, to provide protection to ischemic stress or injury. Also in the skeletal bone, endogenous EPO contribute to the development and maintenance of skeletal bone and bone marrow adipocytes. So there is multi-effect of erythropoietin away from erythropoiesis. And this is a diagrammatic why increased hepcidin by inflammation will decrease iron release from the liver, will decrease iron absorption by effect of ferroprotein, and this will induce also with inflammation, decrease renal clearance of hepcidin and decrease iron absorption in the duodenum. So in patients with sepsis, the question is to give ESA or to hold the ESA, and will come that on the guidelines. If you have a patient with sepsis and hospitalized, you expect non-response to ESA. I think we have to manage that carefully on the following slides with the guidelines. So there is excess iron load, and iron is bound to transferrin. There is increased oxidative stress. That's why iron is not in the circulation as a simple iron molecule. It should be carried by another molecule because the free iron or excess iron can cause severe oxidative stress. The recycling in the spleen and liver provide most of the body iron. Most of the body iron is stored in ferritin, and only 3 milligrams of iron can be found circulating bound to transferrin, which is called the TSAT or transferrin saturation. Now, the commonest of nephrologists is the iron therapy. Which type of iron should be given and which doses? The first is dilemma of iron deficiency state. We have two types. We have functional iron deficiency and absolute iron deficiency. The function is clear. It's associated with TSAT below 20% and serum ferritin higher than those noted in absolute iron deficiency. So if we have a TSAT below 20%, despite that, a very high ferritin, this is called functional iron deficiency. While absolute iron deficiency, we will find that both TSAT and serum ferritin are below the target. It is in the guidelines below 100 nanogram per milli in non-dialysis dependent CKD and peritoneal dialysis patient, and below 200 nanogram per milli in hemodialysis patient. So if you have a patient with TSAT below 20% and the high ferritin, still the patient has anemia, this is called the functional iron deficiency. And if you have TSAT below 20% and still serum ferritin is low, this is absolute iron deficiency. And this is a table you can take screenshot for differentiation between absolute and the functional iron deficiency. If you look to the this row, that in the functional iron deficiency, increased ferroprotein degradation by the effect of hepcidin. So the exporter of iron from different parts, from intestine and macrophage by ferroprotein, is affected by increased its degradation by hepcidin. For sure, all the inflammatory cytokines can induce two major effects. One effect is decrease of the iron mobilization and direct effect on the ESA release and the bone marrow suppression. Now coming to different iron preparation and what is available in Egypt. Ferric citrate, one of the oldest one, which is more than 5-6 years, originally introduced as phosphate binder. And it's noticed that with a ferric citrate as a phosphate binder, it can improve anemia. However, it is not for just iron replenish, like can maintain iron maintenance volume. Still, more gastrointestinal toxicity can induce both diarrhea and constipation. And in patients with CKD undergoing dialysis, ferric citrate is indicated for phosphate binding, but is used on off-label basis as an iron supplement. In meta-analysis of 16 studies of ferric citrate use in CKD demonstrated significant increase in hemoglobin, TSAT, and ferritin level versus the comparators. Still, the price is high. The second one is the ferric maltol, which is a structure protects that ferrous iron while passing through the stomach and provide high bioavailability when the complex is dissociated in the enterocytes. As such, a lower dose of iron has been shown to be efficient with the agent at a 30 milligram twice daily. It increased the hemoglobin and compared with the placebo in the literature, and it's approved by US FDA in 2019. However, new IV iron are present now, and I commonly use one of them, which is the ferric carboxymaltose. And it is actually very effective and cost effective, although in Egypt it's cost around 1,600 per 500 milligram, but in patients not on dialysis, you can save money by giving only 2 doses as day case in 30 minutes, so decrease the load of hospitalization and frequent twice weekly for different, say, 10 weeks to give an iron. So I think one of these important ferric carboxymaltose is given. However, it has a very major side effect, which is called 6H syndrome in 40%. If you don't know the 6H syndrome, don't be upset. I will discuss it on the following slides. So be with us. Ferromixitol was the first IV iron agent to decrease the incidence of anaphylaxis compared to iron dextran due to decrease the intravascular release of free iron. Ferric gluconate, it's an old one. It has an adverse reaction to free iron in the circulation and the dose related. And iron sucrose, one of the commonest iron preparation taken all over decades. The maximum FDA for iron sucrose approved in patients undergoing maintenance dialysis, 200 milligram in patients with CKD not treated with kidney replacement therapy, and around 400 milligram in peritoneal dialysis. So iron sucrose, one of the commonest one, is predominantly used, this formulation, with relative weak iron binding compared to some other iron formulations, resulting in higher plasma level of labile-free iron. This is not an advantage, just a dissociation early from this particle with labile-free iron can induce more of oxidation. And finally, hypotension is a known side effect of such a high dose intravenous iron sucrose. I don't give more than 100 milligram per dose. Ferromixitol is approved, and it's a 510 milligram administration by infusion or slow IV push over a period of 15 minutes. It has been reported that 1,000 milligram can be safely administered over a period of 15 minutes, allowing for iron repletion in a single visit. And this is a ferric carboxymaltose. It's a compound of ferric oxyhydroxide surrounded by a tightly bounded carboxymaltose. The dose usually don't bother by milligram per kilogram. It's usually between 500 or 750 milligram in 2 doses. So the maximum dose is around 1.5 gram split between the doses in 2 weeks. Ferric carboxymaltose 1,500 milligram increase hemoglobin level by a mean of 1.5 gram per deciliter compared with 0.8 gram with oral ferrous sulfate. The serious adverse event is the 6H syndrome. In the clinical study of ferric carboxymaltose, the REPAIR IDA trial among more than 2,500 patients with iron deficiency anemia, there is improvement in the hemoglobin level by 1.13 gram per deciliter in a dose 750 milligram in 2 doses. The serious adverse events were similar between groups. However, the recipient had more hypertensive episodes, and the hypophosphatemia is frequently up to 40%. So if you are deciding to give ferric carboxymaltose, it's a trademark name is ferric injector or injectafer, 500 milligram or 750 milligram. You have to check serum phosphorus between the splitted doses. Ferric maltose with a single 1000 milligram dose versus iron sucrose given as many as 5 doses of different 200 milligram over a period of 2 weeks. In the clinical study showing that the patients in randomized control trial of ferric carboxymaltose and the ferric maltose with respect to hypophosphatemia between baseline and day 35 with iron deficiency anemia, ferric maltose is less effect of hypophosphatemia, but it is not on our market. So who don't know the 6H syndrome? It is seen with various IV iron formulation, but most prominent with ferric carboxymaltose that is thought to occur as a result of what? Of impaired cleavage or inactivation of phosphatenine, which is the FGF23. So let us count 6 names starting by the letter H. A high FGF23, subsequently in patient with remaining renal function, this high FGF23 will induce hypophosphatemia. Accordingly, we'll have hyperphosphaturia, hypovitaminosis D, hypocalcemia, and the last one is hyperparathyroidism. Again, it's reported to be 40% in patients with ferric carboxymaltose. And this is the pathophysiology and the biochemical abnormalities coming from the carbohydrate moieties with increase of intact FGF23 will induce hyperphosphaturia and subsequent hypophosphatemia. So please check serum phosphorus between the splitted doses of carboxymaltose injection. The increase of parathyroid hormone is speculated that to have an osteomalacia or atypical fracture on the long term. However, this is a very short-term complications. Don't be panic on that. And this is the clinical syndrome with iron deficiency and intravenous iron-induced hypophosphatemia. I think many of the juniors are not aware about the availability in the market in Egypt and its side effects. It is very safe drug, but need attention on the follow-up. We are coming for the how frequency of hypersensitivity reactions to intravenous iron formulation is completely rare. And you are panic about hypersensitivity. Still, the guidelines saying clearly don't give IV iron in any facility or hospital not equipped with emergency treatment of anaphylaxis. Although it's 1 to 250,000 doses, still it may carry risk. So the latest guideline saying that don't give IV iron except if you are ready for treatment of anaphylaxis. The time latency between the administration of IV iron and the onset of symptoms is usually rapid. Within about 30 minutes, especially within the first 10 minutes, and such immediate hypersensitivity reactions, including anaphylaxis, immediate non-life-threatening symptoms, such as local irritation, rash, urticaria, angioedema, pruritus, nausea, vomiting, myalgia, or may be developed delayed after finishing the IV infusion. Again, the guideline does not recommend pre-treatment with steroid and antihistaminic. It is a common in practice, I know, to give pre-IV iron, antihistaminic, and steroid. It is not recommended. Also, in the guideline, does not recommend to keep the patient 1 hour after finishing for observation. But still, the strongest recommendation is to give iron in a facility ready to treat. The commonest iron reaction is not the hypersensitivity. The common is the fish pan reactions, which is around 1%, comparing to 1 to 250,000. These fish pan reactions is characterized by transient flushing and truncal myalgia with joint pain. And this does not necessitate stop of iron. Fish pan reaction may be mistaken for prodromal symptoms of anaphylaxis. The delayed IV iron reactions, which is the most common delayed, has been found to be cutaneous exanthema, which is usually considered to be T-cell mediated. Other delayed onset symptoms include fever, nausea, diarrhea, myalgia, arthralgia, lymphadenopathy, or headache. Lastly, ferric pyrophosphate citrate. It was used as a dialysate supplementations, including in a canister of the dialysate. I don't like that way. However, in the study, it can maintain iron, cannot be replenish iron store. It can just administer with each session around 5 to 7 milligram, which approximately the iron loss with each hemodialysis treatment. So in patients with iron deficiency, ferric pyrophosphate citrate will not treat such iron deficiency state. And this is in literature. Again, myself, I don't feel that it's a correct way for the treatment by this expensive, not accurate, and non-controllable of true iron deficiency. So we have iron strategies. We have 2 different strategies. You can give high dose, low frequency, like ferric carboxymaltose, 2 doses, 500 milligram per infusion, or a common practice, a low dose with high frequency in the studies, 400 milligram per month in patients on maintenance hemodialysis, according to the proactive study, is sufficient. And this is the proactive study, depending on the latest KDIGO guideline 2025, on patients proactively giving iron till ferritin approach 700 microgram per liter and TSAT 40%, and it showed that it improved the iron stores, hemoglobin level, and improvement with lower ESA doses. So the latest guidelines is relying on this proactive to give iron as a maintenance therapy around 400 milligram per deciliter doses frequently over a month. What about the use of HIF and prolyl hydroxylase inhibitor, which is a HIF, hypoxia inducible factor? If you don't know that HIF, you can watch the movie of Vertical Limit or Everest or Himalaya. All of these names of the mountains are the clinical trials of the HIF, depending on giving hypoxia inducible factor to increase ESA and increase hemoglobin. What the guidelines say about that, and this is one of the major change in the guideline, in the KDOQI guideline 2025, to add HIF to the guideline. It is the first time. It was only ESA. However, HIF has a position now in the KDOQI guideline. For those who are don't know about hypoxia-inducible factor pruryl hydroxylase inhibitor, or the HIF, it's a novel mechanism of action by mimic body response to hypoxia. That's why all the randomized controlled trials are named by mountains, like Himalaya. Their efficacy in correcting and maintaining hemoglobin has been demonstrated in different phases. Additionally, HIF activation results in various pleiotropic effects like angiogenesis, like glucogenesis, anti-inflammatory effect, and has been recently added to the KDOQI guideline 2025. The HIF are the main regulator of endogenous APO production and iron availability via the following mechanism. One of them is targeting lowering hepcidin level as an advantage point against ESA. It upregulates APO receptors, increasing endogenous APO production, increasing intestinal iron absorption by blocking effect of hepcidin on ferroprotein, promotion of erythrocyte maturation, and inhibition of hepcidin production in the liver. So, major 6 points advantage of HIF over ESA. What is the priority of giving? Shall we give ESA first or HIF first according to the guideline? If you have both drugs available at your unit or hospital, what the guidelines say, what is the first choice? Is ESA or HIF? I will answer this question according to the KDOQI guideline later on. And this is different drugs. We have at a time roxadustat in Egypt, and the effect of different roxadustat, daprodustat, vadadustat, all of these are HIF. And against ESA, the only one and important one difference is the hepcidin. Hepcidin level decrease in all HIF molecule, but neutral in ESA. And this is advantage in inflammatory reactions in patients resistant to anemia, management by ESA. The following few slides is the randomized control trials for HIF against different ESA, like Ibutin alpha. It is the same. It is a phase 3 study of roxadustat versus Ibutin alpha, and both have greater hemoglobin change and reduction in transfusion and IV iron use. However, still there is a point of HIF, including the MACE and thrombosis. The occurrence of cardiac or kidney-related adverse events in HIF group were not so much different compared with placebo or ESA groups, but trend to be higher, slightly higher. Now coming to important points and takeaways. What is the KDOQI guidelines say in 2025, and we are approaching 2 months to have the final version. Use of iron to treat iron deficiency anemia in CKD. Recommendations. Suggesting initiating iron therapy if ferritin below 500, anti-SAD below 30%. In people with anemia and CKD 5 hemodialysis in whom iron therapy is being initiated, it is suggesting using intravenous iron rather than oral iron, and it is logic to give IV iron in patients on dialysis. In people with CKD 5 HD in whom iron therapy is being initiated, administer intravenous iron using a proactive approach to maintain stable iron status. So this is a proactive approach depending on the proactive study, 400 milligram per month, approaching F13 below 700. If ferritin exceeding 700, then you can stop. Unless ferritin is below 700, you're still giving 400 milligram once weekly per week. So initiate iron therapy in hemodialysis patients and grading 2D if ferritin below 500 nanogram per milli, TSAT below 30%, and give as an IV iron. In people with anemia and CKD not receiving dialysis or treated with peritoneal dialysis, so patient CKD not in hemodialysis, but may be on peritoneal dialysis, we have two scenarios. You have to give iron if ferritin below 100 and TSAT below 40%, or another scenario, if you have a ferritin above 100 but still below 300 nanogram per milli and TSAT below 25%. You can take screenshots from both slides as the recent guidelines when to initiate iron. And on all cases, you will give as a proactive approach. The practice point in people with CKD treated with iron, it is reasonable to withhold iron if ferritin above 700 nanogram per milli or TSAT above 40%. It's a clear statement. If your patient above 700 or TSAT above 40%, you have to stop iron. Does not mention here if the patient has some sort of functional iron deficiency. For example, you can have a ferritin above 700, 800, or 900, and the TSAT is still below 20%. Shall we give or not? It's not graded. In the practice point, switch from oral to intravenous iron if there is an insufficient effect of an optimal oral regimen after 1 to 3 months. So if you give your patients oral iron and not responding after 3 months, you have to shift. Irrespective on dialysis or not, peritoneal dialysis or not. Definitely, all patients in hemodialysis should receive IV, not oral. For the monitoring in patients with CKD treated with iron, it is reasonable to test the hemoglobin, ferritin, and TSAT every 3 months for those not receiving dialysis. While on dialysis, and this is a new, not every 3 months, here in the KDIGO guideline saying that every month for those with CKD 5-HED. I think it's not logic to test every month costly ferritin, iron, and hemoglobin and TSAT every month. It's enough to measure hemoglobin. It's my opinion. It's not the guidelines. It's my opinion. And still, you can, in patient on dialysis, you can test whenever needed or to change the doses. In some circumstances warranting more frequent iron testing, according to the guidelines, when initiating or increase the dose of ESA or HEF, episodes of known blood loss, patient with recent hospitalization, importantly, increase in ferritin or TSAT or overshooting target limit, meaning that you are giving too much doses of iron and ESA doses with overshooting above 1 gram after 2 weeks or 2 grams per month. You have to feedback again about iron profiling and ESA doses. The practice point is in people with CKD treated with iron, consider temporarily suspending iron therapy during systemic infection. It's a clear closing the debate. about to give or not to give iron in patient hospitalized with sepsis. For those with systemic infection, yes, we have to suspend iron because iron has many other negative effects. For that reasons, the 4 points demonstrating that IV iron risk of infection, it can increase in observational data. Higher IV iron doses or frequent administration may increase infection-related hospitalization or mortality. In particular, patient prone for that, like in patient with casters. Although the pivotal trial, which compared proactive high dose for 100 milligram per month and reactive low dose, IV iron regimen showed safety outcome. So 400 milligram per month is okay, but if the patient is hospitalized for infection or sepsis, like catheter-related bloodstream infection, we have to hold IV iron. In the meta-analysis supported these findings showing no increased infection risk with high-dose IV iron above 400 milligram per month compared to low-dose regimen. So the overall, to close this dilemma, shall we stop IV iron in patients with sepsis? Yes. Shall we give iron later on? Yes, according to the iron profile. How much iron is required will depend on the patient's status and not maximum 400 milligram per month as a proactive approach, provided the ferritin is still below 700 nanogram per milli. So iron is essential for growth of bacteria and the proliferation of most pathogens. Iron exerts subtle effect on immune function and the host response toward microbes. Theoretical and experimental evidence to suggest iron administration may worsen an existing infection, but still clinical evidence is lacking. Accordingly, IV iron is usually not administered when people have an active systemic infection, such as pneumonia or a catheter-related bloodstream infection. So classically, iron excess may have negative impact on the liver, on the heart, diabetes, hypogonadism, skin-related conditions, and may negatively affect the immune regulatory balance, weakening an immune system. The dose of IV iron should be maximized, taking care of the type, iron sucrose or iron ferrous gluconate, and if the patient on dialysis or not dialysis according to the guidelines. In patient, in the guidelines saying that state of iron deficiency without anemia, you have to treat. So in practice, in people with CKD and profound iron deficiency, but no anemia, consider treatment with oral or intravenous iron. Recommendation 3.1, in people with anemia and CKD in whom correctable cause of anemia have been addressed, it is suggesting here using an ESA rather than HIF as first-line therapy for treatment of anemia. So this is solve your bothering about if you have both ESA and HIF, which to start. You have to start with ESA, but if you have a resistance of ESA or high hepcidin or inflammation, you can shift, but don't start with HIF according to the guidelines. And consider for patients both ESA and HIF for malignancy, active cancer, insufficient data for HIF for post-kidney transplant, and in children. Concern for risk based on adverse event profile in clinical trial, like prior cardiovascular event, prior thromboembolic events, because it's carry higher risk, still statistically not significant, but still higher than ESA. Give iron and ESA according to the guideline stating if below 9 grams per deciliter in patient 5D. But if your patient has different risk factors, such as those with recent stroke or recurrent dialysis access thrombosis, you can accept lower hemoglobin level than in usual because of the avoiding or potential avoiding ESA treatment in those patients. While patients around hemoglobin with lower cardiovascular risk and symptoms or reduced exercise capacity, so linked here to hemoglobin and its symptomatology. You can start ESA initiation when hemoglobin is closer to 10 gram per deciliter. In all cases, the minimum to start is 9 gram per deciliter. The maximum to start is 10 gram per deciliter. Putting in mind iron profile is important to first manage and correct. 3 important steps in patient with anemia and CKD. It is reasonable to suspend ESA using during hospitalization for stroke, vascular access thrombosis, or thromboembolic events. We have to stop ESA in these 3 cases by the KDIGO guidelines. And then reinitiate according to the patient considerations. In patients with anemia and active cancer or a history of cancer, use shared decision-making regarding continuation or discontinuation of ESA therapy based on patient preference, outcome, and especially when treatment is aimed at cure. So ESA could be given in patients with cancer if it's cured, number 1. Number 2, if the chemotherapy induces anemia, you can give ESA. Number 3, if the hematological malignancy, you can safely stay here, ESA. But for solid cancer, as all ESA and HIF can increase angiogenesis by its function, which can increase or disseminate cancer. So it is a decision-making about cancer and solid organ tumors. However, studies in people with cancer have shown that using ESA to treat anemia of some cancer may lead to increased cancer progression and death. The American Society of Clinical Oncology and Hematology Clinical Practice Guideline saying that ESA may be considered in people with chemotherapy-associated anemia and those whose cancer treatment is not curative in intent and whose hemoglobin is declined below 10 gram. According to these guidelines, the KDIGO guideline, ESA should not be offered to most people with non-chemotherapy associated anemia, except for selected people with lower risk myelodysplastic syndrome. When you start HIF, be in mind that of the thyroid function. If you are starting roxadustat, in people with anemia and CKD when dosing, monitor the hemoglobin level 2 to 4 weeks after initiation because HIF-induced spike of hemoglobin increase after 2 weeks. So don't wait a month. If you start HIF, you have to check hemoglobin after 2 to 4 weeks. And roxadustat, you have to monitor thyroid function in patients with anemia and CKD and monitor thyroid stimulating hormone free T3 and T4 after 4 weeks of therapy initiation by the guidelines. Discontinue HIF if no response after 3 months. You have to stop HIF if no response because complication will happen. And ESA may consider in such a case of insufficient production of erythropoietic response to HIF. So ESA should be started if is a subtype below the ESA, and if you give HIF, don't increase the HIF dose, don't continue in HIF more than 3 months if there is no response to hemoglobin, and you have to shift back to ESA. For ESA patients and HIV, suspend the treatment in those who experience cardiovascular events, stroke, myocardial infarction, or thromboembolic events like DVT, vascular access thrombosis, or newly diagnosed cancer. This is an important practical point. When to start, when to stop, how to monitor. Very important guidelines in this version. Coming to my last few slides, hyperresponsiveness, which means that you cannot reach the target hemoglobin while receiving a greater than subcutaneous 300 international per kg per week of epoetin or 1.5 microgram per kilogram of darbepoetin, accordingly around 100 microgram per week, or in such a case, you need to continue a very high doses to maintain the target hemoglobin. So you have two scenarios. Number one, you need very high doses, more than 300 international unit per kilogram per week, or 1.5, or need such a high dose to maintain the hemoglobin level. This is called hyperresponsiveness. And many causes of ESA hyperresponsiveness, including iron deficiency, inflammation, hyperparathyroidism, blood loss, inadequate dialysis, hematological complications, hemolysis, pure red cell aplasia, although very rare, nutritional deficiencies, copper, zinc, folate, thiamine, B12, vitamin E, carnitine, medication, again, RAS inhibitors, or maybe in 30% of cases unexplained. So initial ESA hyperresponsiveness or subsequent ESA hyperresponsiveness need more intensified testing and more approach for these patients. Don't jump of ESA doses because patient will have a stroke or MACE or vascular access thrombosis in those patients. And increasing the doses with ESA hyperresponsiveness will carry more mortality, higher cardiovascular hospitalization, and healthcare costs. For the KDIGO guidelines, hyperresponsiveness, if there is a desire to raise hemoglobin to avoid transfusion, for example, patient needing for renal transplantations. If there is initial ESA hyperresponsiveness, you can try HIF, prolyl hydroxylase inhibitor, and don't patients, if patient with CKD not receiving dialysis or CKD 5D who have active malignancy or a recent cardiovascular event or recent vascular thrombosis, don't use HIF at all. Clear messages from the KDIGO guidelines. And inflammation, we know that can induce. Many patients with known but very rare pure red cell aplasia. And this is for such a patient, we have criteria, must be on ESA therapy more than 8 weeks with high serum ferritin. This is the criteria, including sudden decrease in hemoglobin concentration at a rate of 5 to 10 gram per liter per week, or requirement of transfusion at a rate of approximately 1 to 2 per week. In this pure red cell aplasia, all ESA therapy should be stopped. No routine screening for anti-erythropoietin antibodies among people with CKD, and challenging for the treatment in such case with individuals who remain transfusion dependent. I will pass this one because bone marrow examination confirmed severe hypoplasia or erythroid precursor less than 5% for diagnosis of pure red cell aplasia. Final points, and in just a couple of slides, the blood transfusion for our juniors. Be aware that if you are giving blood transfusion in hemodialysis, you have to start with fresh blood, not stored. Transfusion must be started 15 to 30 minutes after commencing dialysis. Don't give blood transfusion at the end. Never. Just to start 15 minutes because potassium is enriched in the pack. We have to take care about extra fluid to be removed. Patient should continue to be dialyzed for at least 30 minutes post-transfusion because serum potassium may jump. Don't finish the pack of the blood and the dialysis at the same time. Give at least 30 minutes by the end. Blood is transfused pre-dialyzer. Definitely don't give directly to the arteriovenous fistula because there is thrombosis, microemboli. Don't give that in a separate line. It should be given in the pre-filter line. Blood pack may contain up to 20 millimole potassium, so transfusion induced. Also, in patient for transplantation can induce HLA sensitization in kidney transplant recipient. And this is how the sensitization of the donor and the recipient sensitization of the both. HLA antigen exposure via red cells, class 1, and residual antigen presenting cells, class 1 and 2. White blood cells should be removed because it's a very immunogenic. And this is called leukocyte depletion red blood cell transfusion, meaning that the leukocyte count should not be more than 1 per 10(6). White blood cells remain per unit of red cells. You can count that by the blood bag you receive for patient is ongoing for transplantation to detect how much white blood cells is retained. Leukocyte can express class 2 HLA antigens, and these residual leukocytes are the reason why leukocyte depletion does not prevent transfusion-induced sensitization. White blood transfusion cannot be avoided other than supplying leukodepleted blood that prevent transfusion-induced sensitization could further be supported by provision of HLA selected red cells to minimize the HLA mismatch between donor and the recipient. By this slide, I finalize my talk, and be aware of prevention of transfusion-induced sensitization and HLA selection red cell at patient with sensitization in the pre-transplant setting. And thank you very much.
هشام
رامي معايا؟
معاك هشام.
طب كويس ان النت ما قطعتش الحمد لله.
Thank you, Professor Hesham, for this very comprehensive lecture about management of anemia and CKD and end-stage kidney disease, starting from important points about sampling of blood in dialysis patient, when to sample, how to sample this blood. Very important, really clinically important point. Iron metabolism, iron tips and tricks, iron intake, iron formulations, iron indications, iron contraindications, iron side effects, and important numbers about the iron TSAT ferritin in CKD dialysis, hemodialysis, peritoneal dialysis, the use of ESA therapy, the use of when to use ESA, what are the side effects, when to stop, how to continue, dosage, HIF stabilizers, when to use, indications, really specified each point of this, ending with the transfusion, blood transfusion, when to give how to give blood transfusion, and as usual, not only academic points of view, clinical points of view, when to give on dialysis, how to give on dialysis, when to stop, when to start, and in cases of transplantation, what are the measures taken to blood transfusion or blood transfusion in these patients. Thank you, really, and full of clinical details, and we have many questions during all the session. Professor Saeed Khamis wants to comment first. Professor Saeed, your comment. ونبتدي ناخد questions. Okay, I think Professor Saeed is out.
We can take some questions.
Take some questions. A question about from Dr. Tawfiq Morsi. Is there a cut value for blood pressure at which we should not give EPO injection? And the role of iron chelators in patient on dialysis in cases of iron overload, higher level of ferritin.
For the first question, you have to control blood pressure in generally before giving ESA, and you have to control the dry weight if the patient on dialysis or others, because as I highlighted that ESA can induce insulin and it can aggravate uncontrolled blood pressure. So my answer, yes, I can wait, provided that the patient can control blood pressure within a short period, either on dialysis to reach the target dry weight or to control patient compliance of medications and salt intake, and then you can start. There is no hurry on that. For the second point, we don't use dysferal or dysferoxamine or iron chelators, maybe more than 3 decades. We have to treat inflammation, which is usually the cause of hyperferritinemia. In pediatric patients with frequent blood transfusion or thalassemia or hemolysis, yes, you may have some high iron overload status from frequent blood transfusion, but still there is no sufficient data in the guidelines considering iron chelator in such patients.
Okay, thank you. Question, I think you illustrated this point clearly about the allergic reaction from IV iron. From Dr. Sylvia Hanna about HIF drugs in patients with decompensated liver cirrhosis.
No sufficient data for pediatric or advanced liver disease. For HIF or pregnancy, still the randomized control trial does not include all those patients, so I don't recommend. In advanced liver cell failure, we have to, according to the guideline, we have to start with ESA in all cases.
Okay. You don't start with ESA in all cases in those patients, huh, Professor Hesham?
We have to start with ESA in all cases in general practice and reserve HIF for those who have hepcidin level inflammation or an alternative to ESA according to the guideline. First line is ESA, second line is HIF. If you have liver cell failure, pregnancy, or pediatric, there is no sufficient data in that.
Okay. It's clear message. And is 3 questions. Can iron infusion be given in functional iron deficiency anemia?
If the ferritin above 700, we have to treat first functional iron deficiency, the cause. You have a long list.
To treat first the cause.
Yes.
Can we
don't push because free iron is toxic. So if you have a ferritin above 700, T-set is around 20 or 30, and still patient, you are building up too much doses of ESA, you have to stop all of that and to treat the cause.
Okay.
That's my
question.
opinion. I don't know if you have another opinion, Dr. Yes.
I think the same opinion. Yes, treat the cause first, no hurry to treat such patient. Totally agree with you.
Iron is toxic. Iron is toxic.
Iron is toxic. And as you mentioned, has many side effects. It's not a simple drug that to be given as a usual drug medication of dialysis. Can we get ESA in a more frequency, 5 days per week, more than every 3 times per week in dialysis patient?
5 times per week?
Yes.
No, it's giving for practice. In some countries, they are giving 3 times a week IV in patient on dialysis because no need for subcutaneous injection, but this is on the expense of around 25% higher doses. In low and in medium income countries, I prefer subcutaneous because it can be given with lower cost 25%. But 5 times a week is not recommended. It's 3 times as a maximum.
Yes, يعني we can increase the dose according, but the duration is fixed at for a maximum of 3 times per week.
Yes, you can start with yes per kg and building up accordingly. Yes.
Okay. طيب سؤال من دكتور معتصم السيد. A patient has documented ودي I think in this case we all faced in our clinical practice. Documented hypersensitivity reaction to iron sucrose, and now presents with anemia around 9 grams per deciliter and an absolute iron deficiency. What are the potential strategies for managing such case?
I give ferric carboxymaltose. It's more safer in 2 single doses, 2 subsequent doses, 500 or 750 milligram per dose. But check serum phosphorus. In patient on dialysis, don't be worry about serum phosphorus, but in patient not on dialysis, we have to check that. I think because the stability and the hypersensitivity reaction with ferric carboxymaltose is less than extremely than ferric sucrose. However, the fish pan reaction is the commonest, not the hypersensitivity. So differentiate between both, just myalgia, flushing, or true urticaria rash, asthma, hypotension. So fish, we have to first differentiate between true hypersensitivity reaction and fish pan reaction.
Fish pan reaction. I think the more common we face is the fish pan
fish
reaction.
Pan, yes.
Fish pan, not the true hypersensitivity. أنا ما شفتش الحقيقة. Frank hypersensitivity دي من iron.
It's uncommon to find severe hypersensitivity reaction or delayed hypersensitivity reaction. So there is no recommendation about that to give the patient steroid and antihistaminic before, or to keep the patient on monitoring 1 or 2 hours after the IV iron.
تمام.
بس ما يتاخدش في البيت يعني
هو الحقيقه ما يتاخدش في البيت، لازم يتاخد اندر ستريكت ميديكال سوبرفيجن ومش في اي مكان.
Yes, exactly. في مكان equipped for the management of hypersensitivity reaction and shock.
يعني ايفن حتى الايرن ديفيشنسي انيميا، يعني في براكتسز ان هي غريبه ان هو العيان ياخد 1 امبول اوف ايرن ويروح، وبعد كده هو اتعالج عايز او انذر امبول وبياخدها في اماكن في عياده او يعني مش
لا it's not yes it's not safe and not recommended and clearly stated by the guidelines.
Okay, sure. Thanks for clarification of this point. A question about vitamin B12 and folic acid replacement. What's your opinion, Professor Hesham, in this?
We are abusing too much of vitamin B12. All my patients who are tested vitamin B12, the stores is very high. Be in mind that vitamin B12 storage in the liver, it is not such removed by dialysis. Against, for example, thiamine and the other B vitamins. If you have a long story of pernicious anemia or malabsorption syndrome, testing vitamin B12 in the literature, yes, you can test the vitamin B12 and the folate. If you are not sure that there is the response, response to treatment of anemia. But if you don't have weak response, you will not be in need to test.
And I think there is malabuse also of folic
Yes.
acid treatment in CKD and anemia.
Yes,
I'll
exactly.
From Dr. Arola Osman about EPO in sickle cell anemia.
It's a tricky question, Yarola. I reserve that for the sickening hematology, but I don't recommend.
بالظبط. How much if the patient having chronic anemia from دكتور المجدد أو محمد المقداد محمد, if the patient has chronic anemia depending on transfusion serum ferritin more than 700 and has bone marrow aplasia and was on regular ESA, what is your recommendation?
If you have a bone marrow aplasia or dysplastic changes or mono or bicytopenia or pancytopenia, there is no place of ESA.
Place for ESA.
You will have complications by ESA like thrombosis, MACE, and strokes, vascular access thrombosis, and the still bone marrow will not be responding, like in patient with bone marrow fibrosis or myelofibrosis.
I think the question is about pure red cell aplasia, not bone marrow aplasia.
For pure red cell aplasia, which is definitely very rare, the first step is to stop ESA.
Okay, sure. And the treatment then is difficult for this, but the first is to stop ESA.
It will be dependent on blood transfusion.
Blood transfusion. Hemolytic reaction. Some patients end-stage kidney disease on hemodialysis develop hemolytic anemia proved by labs. How to approach these patients? I think the question.
You are saying hemolysis during dialysis?
Hemolysis, yes, hemolysis during dialysis.
This is my talk tomorrow, inshallah. Yes, increasing shear stress, just a clinical hint, don't give up a high blood flow in a weak fistula. يعني يكون vascular access very weak and you put the patient on 350 or 400. This increases the shear stress. You have to check all the hemolysis factors for dialysis, including residuals. You have to check LDH, and this is an episodic. It is not a regular. It's an episodic attack of hemolysis. If the patient has persistent hemolysis, we have to check the COMS test and other autoimmune disorders that can carry hemolysis irrespective of the dialysis prescription.
انت بنستناها منك المحاضره دي هنا بقى يا دكتور هشام المره الجايه ان شاء الله.
طيب حاضر.
طيب question about how much an increase of hemoglobin هذا the incrimination of hemoglobin
rate, you mean rate?
Increased hemoglobin per month. If there is any limit for increased hemoglobin per month, a rate
Yes.
of
Yes, it's dependent around 1 gram in 4 weeks. In particular, when I'm using HIF, it may have a spike above that in 2 weeks. So the recommendation, if you're starting HIF, you have to check hemoglobin after 2 weeks.
2 weeks. Like
Yes.
otherwise, 1
1
gram.
month, 1 gram.
1 gram per month. Last question about IV ascorbic acid and L-carnitine. L-carnitine in treatment of anemia.
You are memorizing myself 30 years ago when I started literature. I published that at that time, small dose ascorbic acid for patient in response to ferritin, just giving less than half gram per session. It increased the hematocrit. Really, it increased the hematocrit in patient with the resistance. Nowadays, with more advanced of perfect dialysis, I think we are stopping giving ascorbic acid in that.
But still giving carnitine, L-carnitine.
L-carnitine has many effects in the mitochondria metabolism. In the nutritional guidelines, yes, they say that it may benefit, but you know that it's one of the factors you can manage by inertia, giving L-carnitine and giving vitamin and giving B12 too much in patient on dialysis. It will not be an hazard, and I accept that giving L-carnitine.
Okay, this is the usual practice, giving L-carnitine in dialysis, in addition to vitamin B12 at the end of the session. طيب احنا كده no questions يا دكتور هشام. No more questions and no more.
I would be happy يعني if any other questions.
ثانية واحدة. I think في questions زيادة. What we do in functional iron anemia, you clear this point. ممكن نشوف التسجيل هتلاقوا حضراتكم موجودة in details. Is anisocytosis in blood film after replacement of IV iron with TSAT 28%. Anisocytosis in blood film, but hemoglobin level and response is not mentioned. Only anisocytosis. What's your opinion?
Different shaping of the red blood cells for microcytosis, and even after blood transfusion, you can have normoblastosis with macrocytes inside. So I think in the guidelines saying clearly the laboratory markers of both combining ferritin and the TSAT, which is more important. In the UK guidelines, they are giving additional factors like microcytes testing, but it's I think it's not of practical to be implemented to give too much testing of red blood cell shaping and microcyte percent.
Not stated.
Yes, we have to strict to simple testing, very cheap to do, very easily to be interpreted, the TSAT and the ferritin, and you can decide below 700 ferritin or above. You can give a proactive approach. So يعني مش عايزين نعقد المواضيع قوي يعني.
بالظبط كده، ما هو ده يعني احنا فيري رير ما بنلاقي مكان فيه ارقام بالتحديد 30% above 100 above 70. يعني دايما السؤال بيكون about the number, what is the number, what is the limit, and usually we do not have an answer. Here we have clear points, clear numbers, and I think we are lucky here to have this. فمش عايزين نعقد الامور وندور على
اليو كي يعني بيحطوا البرسنت اوف مايكروسيتك سيلز يعني I think يعني يعني خلينا كده في
واضحه جدا وصريحه
في الكلير سايد يعني
very clear وما فيش داعي. About the use of HIF stabilizers in malignancy, patient with history of malignancy, what's your opinion? And of course resistant to EPO.
For malignancy, as I demonstrated that, be in mind that HIF will increase angiogenesis and increase vascular growth factors and dissemination of solid organ depending, يعني malignant tumor depending on the vascular growth factors and new angiogenesis to spread, to save the cancer cells. If you are giving HIF in solid organ, will induce more angiogenesis and carries the risk of dissemination. Both ESA and HIF, but HIF may be more. So I don't recommend in uncontrolled solid organ tumors, except if the chemotherapy-induced bone marrow suppression you can give, but not just saying that cancer you give, yes. No, you don't give exception. So the القاعدة, no, you don't give except in malignancy by chemotherapy induced and the cancer is curative.
And in the end, I think if we don't have another solution rather than transfusion, we are to go to transfusion, not to struggle with a contraindication or something like this.
Yes, because the same mechanism of cancer can induce by the HIF molecule, vascular endothelial growth factors, and new angiogenesis.
Role IV iron and uncontrolled hypertension, what's your opinion?
Not related to each other.
Okay, clear answer. Thank you so much, Professor Hesham, for this very interesting and very comprehensive lecture as usual. كنا سعداء جدا بالمحاضرة وبوجود حضرتك
انا اسعد والله.
كالمعتاد معانا كضيف سبيكر
لا
هذه المرة،
الاي اس ان تي از اور هوم.
مش حضور كالعادة. Thank you so much. Very comprehensive lecture. Thank you for responding to all questions.
ويلكم.
And thank you for all attendees for their active share and for questions اللي enriched بالحلقة. عملنا حلقتين، حلقة للlecture وحلقة للquestions. And thank you so much. Thank you again, Dr. Rami Abu Bakr, for your efforts. And think coming to the end of this very interesting session. Excuse me to close.
Thank you very
تصبحوا
much.
على
See
خير.
you. انتم من اهلا
تصبحوا على
ان شاء
خير.
الله.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمه الله وبركاته.